So 36-year-old, 38 BMI, full months of amenorrhea, about to deliver, right? So here, don't be scared about this. Here really we are going to learn our mistakes. Here this simulation workshop is to learn or just to see our mistake. We are not going to prove yourself best. We are really here to create mistake. Then only we can learn and we can reproduce the great result, right?
We have selected volunteers who themselves have faced such scenarios many times in past. And we know that you know how to tackle such situation. But we want to see and learn something more out of this. So we hope and
so remaining delegates, don't worry, they are not teaching us. We are seeing them, how they are dealing, and we are learning from their mistake or from their skill, right? And yes, here another thing is, how much we are ready for just to call for help. We should know our limitations and we should take, here it is the team approach.
yes.
હલો, બહુ દુખે છે, બહુ દુખાવો થાય છે. દુખાવો કેવી રીતે ઓછો કરો? એપિડ્યુરલ છે શું તમારી પાસે?
By the time they arrange, we take the note of gracious presence of Dr. Pandurang Rotithor, Senior Assistant Professor from Vaghela Institute of Medical Sciences, Dahanu, with his 3 PG students and an AP. They have come here all the way from Dahanu.
Welcome, sir.
બહુ દુખે છે, મદદ કરો. बहुत दुख रहा है, कुछ मदद करो, पेन कम करो. पेन कम करने का इंजेक्शन दे दो साहब.
Can we start with this? Any 36-year-old?
We are doing it for the first time and there are going to be some teething problems, but please be patient. Ultimately, we will come out with a great workshop here.
प्लीज हेल्प, दुखावा बहुत हो रहा है.
No, once, so...
Local language is welcome, so no problem, you can go ahead and deal with the patient.
Okay, so can you, how are we proceeding? Just...
She's in labor.
Okay, so she's in labor and... Okay, okay, क्या हो रहा है आपको?
बहुत दर्द हो रहा है.
अच्छा, कब से दर्द चालू हो गया है?
2 घंटा हो गया सर.
Okay, so and what is
बेबी नीचे आ रहा है क्या?
So should we check the fetal heart, the stethoscope?
By that time we should focus
And,
on the
CT is
screen,
reactive
see the
fetal heart is
monitor,
fine.
vitals.
So can we do a per abdomen examination, check for uterine tenderness, and do a pelvic examination?
Yeah, you can, gloves are there. What we normally routinely do is in labor. Whatever you do, you can...
Perfect.
So we can't hear the obstetrician's voice.
Loud karo. Okay ji. Okay.
बहुत दुखे છે, કઈ મદદ કરો.
Okay, एक बार अंदर से चेक करें. हिंदी, right?
Yeah, definitely.
So do a pelvic examination.
Okay.
Can you tell me the findings?
She's about to deliver. Push, you can deliver her.
Oh, I can deliver her?
Yeah.
So,
Yeah.
so I think she'll have to push, but...
Yes.
So yeah, she is fully dilated. Head is on perineum. And...
She is about to deliver.
Yeah, but how?
So keep things ready.
Oh, pull the baby out.
બહુ દુખાવો થાય છે જલ્દી.
Yeah, but she has to... okay, so they will...
Yeah, baby.
Oh, she will deliver. How is it?
Doctor obstetrician, have you called your sister? Have you called your team for the help?
You can contact, you can pull the baby.
If you're going to deliver a baby, have you
Deliver.
called your team?
Acha, pull. Okay, so there's some liquidy thing here. I'll get a glove. हाँ आइडिया नहीं है पहली वक्त जैसे सॉरी
Sister inside labor room.
Neonatologist. Yes, I would prefer to have a neonatologist.
Call your sister for help, sir. You're going to deliver baby.
So, and we'll have a nurse with the trolley. So, no, but पहला staff nurse कोई
Staff
चीज़ है.
is inside. It's
हाँ.
inside with you.
Thank you.
इसमें ऑक्सीजन नहीं है आपकी इसमें मैं
Okay.
क्या करूँगी अभी बच्चों को ऑक्सीजन कैसे दूंगी
Sorry.
ऑक्सीजन नहीं है बच्चों को ऑक्सीजन देना है आपकी इसमें ऑक्सीजन नहीं है
But one second. I think we are in the OT, right? So, ऑक्सीजन नहीं है. लेबर रूम में ऑक्सीजन तो रहता है ना?
Yes, of course.
हाँ? नहीं है. लेबर रूम है.
ऑक्सीजन खोलने के लिए प्लीज ऑक्सीजन सिलेंडर खुलवाइए मैं पेशेंट को ऑक्सीजन
बट
देना
सेंट्रल
चाहती हूँ।
ऑक्सीजन रहता है ना हर जगह. सो
और ऑक्सीजन चालू नहीं है आपके यहाँ पे
उसमें खोलने का कुछ जरूरत नहीं है.
आपका पेशेंट है आपका ओटी है
हाँ, आपका इसके लिए बोला कुछ खोलने की जरूरत नहीं है. ऑक्सीजन भी चल रहा है. रिससिटेशन ट्रॉली है आपके पास. नियोनेटोलॉजिस्ट. બટ કહીને કઈ આપવું નથી આપણે. ઓકે, સો આઈ ડોન્ટ વોન્ટ ટુ ગિવ એનીથિંગ. શી ઇઝ ફાઇન. ઇફ શી ઇઝ ઓકે, આઈ ડોન્ટ વોન્ટ ટુ ગિવ નો ઓક્સિજન. યુ આર ધ નિયોનેટોલોજિસ્ટ. There is a full neonatal trolley here, resuscitation trolley with oxygen, central oxygen, vacuum, everything is available along with this thing, right? So can I have the staff nurse to lay the trolley for me here?
Now you come to action.
Yeah, so okay. So now can I have some
બેન કેટલું બહુ દુખે છે
can I have some lignocaine to use for anesthesia,
હમણાં
for local anesthetic?
હમણાં લોકલ આપી દઈએ તમને
Okay, so once you give the local anesthetic, खोल नहीं चल से वेस्ट काम कर. हाँ. अरे तो हाँ छे वजू छे.
You are the leader.
वेन लिया है सब कुछ लिए. हाँ, local will give. Okay. So दे दिया ना. हाँ, local given. Okay. And we'll give an episiotomy. Do you want me to do it? Done. So can we deliver her now? Okay, but someone needs to push or the patient will push or no?
Patient push करो तो
हाँ.
Yes, you can.
नहीं फंडल नहीं. पेशेंट भी अरे फंडल नहीं देना है. पेशेंट को बोल रहे हो पुश करने के लिए. हाँ हाँ ओके 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 ओके. हाँ हाँ कॉन्ट्रैक्शन इज देयर. जस्ट फंडल नहीं देना है. नहीं तो वैक्यूम किधर करेंगे हम.
હા બહુ દુખે છે
चलो हाँ पुश पुश पुश. नहीं बेटे આપણે ફંડલ નથી આપવાનું है. डिलीवर करवाना.
ડિલિવર હો ગયો
हाँ आई कैन पुल आउट द बेबी. ओके
ડિલિવર હો ગયા
हो रहा है डिलीवर हो रहा है.
બેબી કેવું છે મારું
ओके
બાળક કેવું છે સાહેબ
Yes.
સર
that is the
નિયોનેટોલોજિસ્ટ
baby
હમણાં જોઈ. સો વી કેન વી કટ ધ કોર્ડ હિયર.
delivery. Okay.
સાહેબ બાળક તો સારું છે ને
हाँ कैन वी कट एक्चुअली कट दिस. नहीं 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 नहीं
સાહેબ છાતીમાં બહુ
नहीं कट
દુખે
करो नहीं ना भाई.
સાહેબ
हाँ 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 ओके हाँ हाँ निकली जैसे कट नहीं करो यार. कैन वी हैंड द बेबी ओवर टू द नियोनेटोलॉजिस्ट. वेयर इज द नियोनेटोलॉजिस्ट.
છાતીમાં બહુ દુખે સાહેબ
सॉरी
દુખાવો ચાલુ થઈ ગયો છાતીમાં
છાતીમાં દુખાવો થાય છે.
સાહેબ કઈ હલો छाती में दुख रहा है सर
कुछ नहीं अभी 2 मिनट के पल्स ऑक्स एंड so pulse rate everything is fine. It's okay. SpO2 is going down. So can we start the oxygen please? And no हाँ हाँ एनेस्थेटिस्ट हमें बोला नर्स है कि एनेस्थेटिस्ट ने बोला है.
Hello.
So in house anesthetic.
सांस नहीं ले रहे खांसी आ रही है सर
So
दुखावा ज्यादा हो गया
so can I deliver the play?
Now
They
the
delivered
audience
the
can
placenta
note the
has been
falling
delivered.
circulation here. The SpO2 is falling.
बहुत तकलीफ થાય શ્વાસ લેવામાં
It
સાહેબ
has come down to 89.
Auscultate
And there is tachycardia as well.
Sure.
Tachycardia as well.
So you know the
given hydrocortisone given 200 milligrams
સર શ્વાસ લેવામાં તકલીફ થાય ચેસ્ટ પેન हो रहा है
Hello.
Would you-
breathing or not? See,
there is no bleeding here. So
okay,
you want to
fine.
check?
So ask,
Patient is breathing.
Now see the saturation falling. It's 81 now.
ગભરાટ થાય સર, ગભરાટ થાય.
Again, skull to the
Pulse
chest.
still rising.
ગભરાટ हो रही है.
Would you like to put in eye gel or something that?
Auscultation. Chest is clear.
Sir?
Still crabs are there and spasm.
सर बोल नहीं सकते हैं.
Repeat Lasix and repeat diary file.
सर बोलने में तकलीफ हो रही है.
Start some minor drops, sir. Blood pressure is too low. Blood pressure is too low and tachycardia.
Syringe pump.
Keep
2 ml in 50 ml. Start with 10 ml per hour.
Dr. Uma, please be clear in your
2
statement.
ml
So
in
just
50 ml
should be
and
audible
2
enough.
10 ml
We are not
per hour.
hearing
Start.
any of your commands.
Get the intubation trolley ready. Resuscitation cart ready.
Yeah. Notice start.
Yes, Narendra started. Ambu continue करिए please. Yes, but SpO2 is still low. We have to intubate the patient.
Okay, now I am intubating the patient.
This patient is obese, so you can go.
Can
with
the audience
Kapadia also.
appreciate the falling
Your
BP,
patient
falling
fever is
SpO2 and
38.
rising pulse here? It is 60 by 39,
Your patient's
70
BMI is
SpO2.
38. Do you need any other thing to intubate this patient?
We
Dr.
can
Uma?
keep eye gel, sir.
So trachea is not visible.
We can keep.
Yes, your patient's
Going for
BMI
help.
is 38.
Give me eye gel.
Yes,
Okay,
eye
okay.
gel
Tube
is
is passed.
intubated, sir. Thank you.
Connected with the ventilator. Check the bilateral entry.
Blood pressure is also falling down. Just check it.
Okay. Then I am removing the tube. I am passing the eye gel.
Sir, start. We must start.
Now the
Your patient
supraglottic,
is collapsed now.
IGL, this is IGL. This is IGL. Actually, these supraglottic airway devices are a boon to all of us.
They couldn't
In
pass
fact,
tubes, so they
instead
can
of struggling for intubation, we can easily, obstetrician also can put, and IGL is so easy to put.
Yes, saturation is
So you
coming
can just
back,
put and start ventilating the
but we
patient
have
and
to
give
do
100%
something to
oxygen.
raise the blood pressure and lower the heart rate.
Is your patient is on
Saturation is again not coming.
You give scoline.
I request all the obstetricians sitting here to encourage your anesthetists to use supraglottic airways more often
is coming
than
now.
before. Because then you are also used to such scenarios. SpO2 is 79, sir.
We are struggling with the intubation.
They have not started yet ventilating the patient. They are intubating yet. BP is 60 here.
Yes.
So there is tachycardia. That
Yeah, we have intubated.
Yes,
We have
yes.
intubated.
This patient is collapsed now.
After the scoline, we are intubated the
Second
patient.
line is taken and the
Dr.
IV
Uma,
fluid is
please tell us,
started.
is there patient is on NORAD? What other drugs?
Increase the
Bleeding
cuff
अभी
volume.
हो रहा है.
No, there is no bleeding. There is no bleeding.
Sir, when the uterus is
Well, uterus is well contracted. There is no bleeding here.
So the reason for that
NORAD?
tachycardia, they have started NORAD infusion, noradrenaline infusion.
Second IV
Heat
line
shock.
taken, we have to start something else along with Narendra. There is no blood pressure recording. And saturation is still not coming. Yes, dopamine we have to start. Yes, dopamine started, sir.
Audience is asking whether it is
Adrenaline
enough
infusion
Alexis.
is getting ready.
ECG is there.
team inside in black box, audience is asking you whether there is anaphylaxis.
Adrenaline in, 1 into 10 and 2 ml bolus has been given and infusion has been started. Norret is still going on, but blood pressure is not recordable.
Do you need to handle your pulse rate
Yes,
or the heart
SpO2
rate?
is coming. BP is also coming. Good. Continue all the Norret, dopamine and adrenaline drip. Continue ventilation. You are ventilating
Now the
in a
patient
good
is on
manner.
ventilator with oxygen.
Blood pressure is coming up.
Tubes should be fixed.
Yes. Yes.
You can appreciate they have succeeded in intubating the patient, giving oxygen. The BP is improving now. The SpO2 is also improving now.
CBC has been
Tachycardia
set,
persists, but it will take time for it to settle down.
APG देखते हैं.
In view of Norret
APG
running,
BP is coming. BP is coming.
Yes,
So
but
now we
have
are
to-
ventilating the patient with 100% oxygen with
Pulse rate
ventilator.
is coming down. That's a good sign. Investigations we have to check for.
Take blood
So,
sample.
so we'll send a CBC, we're sending the ABG as the anesthesia, we'll send the creat and
Hemoglobin is 14 grams, 11 grams. Creatinine is 1.
Magnesium level and
potassium.
Potassium is 3.8.
pH.
pH is 7.1.
Okay, it is acidotic side. So give soda bicarb. Give soda bicarb. 10 ml. 10 ml IV state.
We'll call up. We'll call the scenario.
10 ml.
Thank you.
10 ml.
We'll have everybody outside.
Out?
A big round of applause.
Thank you. Thank you, thank you.
thank you. So there you have seen how a timely resuscitation can help bring back the patient.
So here, 36 years old lady, BMI of 38, about to deliver. They delivered a baby, and along with
Can we have everybody on the podium? All the
delivered a baby with episiotomy and patient collapse, and anesthesiologist revived the patients with attempts of intubations with injection noradrenaline, adrenaline, derifylin and the hydrocortisone, right?
I think good big round of applause to everybody. At least. How many of you have encountered a similar situation in your practice? Each one of us. So, what do you think? What was going through your mind when the patient's blood pressure fell and tachycardia?
So initially in any of these scenarios, first you're looking at if there is any sort of obstetric causes which are causing hypovolemia to begin with. If that doesn't happen, there are a lot of things that happen when suddenly there's a collapse immediately post-delivery, like amniotic fluid syndrome or some sort of anaphylaxis that can happen immediately. That's the first thing that goes through our mind and the reason why there is a sudden obstetric collapse.
Please take this. Please take it. Please be complete. This will go on for about 40 minutes. Yeah. Madam, please come on to the forefront. Yeah.
So I said,
Suppose if you feel that this patient collapsed, what would you do? What would have been your response?
So yeah, the first response is ideally is to be called for the help, anesthetist help.
So too much of help was there. Too many
Yes,
people
yes.
were there.
Yeah.
Little chaos actually. So what happens is, as I said, the captain of the ship is very important. And please, I want only 2 people inside. Remaining all, please be seated outside. I'll call you as and when necessary. Because they'll just hinder the process of resuscitation. Too many people, because too many people, too many thought process, and the bystander, audience, is it anaphylaxis, is it something is, so everybody will give a free for all, basically. So whenever there is free for all, nothing goes targeted. So that is one thing, yes. Then what else?
usually what happens, especially in case scenarios like this, when she's just about to deliver, there are few people who are already around. Right?
So you are there, the nurse is there.
We are there, the nurse is there. The
Anesthetist was there, pediatrician was there.
Correct. So neonatologist is usually there. And if there's an epidural, the anesthesiologist is also
Yeah.
usually around.
Yeah.
So usually there's a good set of qualified team who's already around us
Yeah.
to help manage and pick up the situation early. So I think that makes a big difference.
Absolutely. So when you were intubating the patient, what was the thing that you had difficulty? Because the tongue was swollen. We intentionally made a difficult intubation. Upon that, she was a BM of 38.
Patient was obese, one thing. Second thing, because of pregnancy, edema is there. Laryngeal edema and some epiglottis also.
So could you have modified your technique of accessing airway?
Just I look at the patient and I think it is short neck or obese patient. So I use the extra large laryngoscopic blade.
So
And
best-
I take a help of sister to give pressure over the larynx.
One thing which I want to highlight is how many of your nursing homes you have video laryngoscopes available?
So many.
So best thing is the first attempt is the best attempt. So use video laryngoscope in the first go. Don't, because this patient already has crashed and your blood pressure is 70s and 80s, you don't have much of time. So there is something known as, is a recording ready? Can we play the scenario?
Yes.
તમે કહી તારે
Sir, what? Sir,
I
one
just
thing is
wanted
that-
to know from you, and you have rightly suggested the start attempting intubation with video laryngoscope. But in case it is not there, you try to intubate and like he did, you go for supraglottic airway. But then we are taught that don't use supraglottic airways in a non-fasting patient. So if the patient is not fasting, still if you, will you put SAD or you will persist on intubation?
Basically, again, I must tell you that airway is one topic where we can have and CME entire day, and again it will be inconclusive. So, but in a nutshell, to answer his question, in this case, video laryngoscope is the best attempt. If you fail to do laryngoscopy, second attempt should be SGT, supraglottic airway device.
Now Dr. Sunil conveyed two messages. Be a leader for your situation. So whoever will be the either obstetrician or the anesthesiologist. And the second one, here the BMI of 30 or just by looking your patient, just think of what should be the first way to deal with the act.
I think what's
Sir, 1 minute.
So till now
I don't want to.
I think what's also important is if suppose the anesthesiologist is not there to access the airway, so what you should do is call for help, but in the meantime you can put the eye gel or
See,
supraglottic airway.
this patient is breathing spontaneously. Could you have done something before the anesthetist came and the patient's saturation is appalling?
That's what I said. Once, if she's breathing or not breathing,
She is breathing spontaneously.
then you can start with oxygen, nasal oxygen.
See, nasal oxygen is what is, this is what is important. When the patient is crashing, there is only one oxygen device, that is, you need to give more oxygen. Give 15 liters per minute oxygen with high flow oxygen mask. No nasal oxygen, no Hudson's mask. Have NRBMs, non-rebreathing airway mask. We have plenty of them thanks to COVID. It has done certain good things also in terms of upgrading the infrastructure of hospitals. NRBM masks are universally available now. Have one or two in your labor room, in the theatre, ICU or recovery rooms. So when the patient, normal patients, you can put nasal prongs. When the patient has become tachycardic, hypotensive, the dictum is 12 to 15 liters of oxygen and NRBM, no nasal oxygen, because you can give at least 70 to 80 to 90% of oxygen with NRBM mask till the anesthetist comes. Okay, so don't lose what you have in hand. So you can upgrade this thing. Anything else you could have done? As I said, A, B, C, D, E, UPS. Just activate. See, whenever the mother collapses, just activate the algorithm. Am I dealing with anaphylaxis? I have given local anesthetic. Is it something? I have given antibiotic. Is it something caused this? So is it anaphylaxis?
So what we usually do is secure another IV line, preferably large bore IV line.
Now in the school mind, you're taking another IV line, but in that situation,
No, that
IV
was
line-
already taken, and I had the anesthetist doing the job.
Good.
Right.
Great.
So I didn't need to focus on that at all.
Is it ready? Yes. Yeah, can we play the scenario? हाँ थोड़ा फास्ट बात करो थोड़ा थोड़ा फास्ट वर्ड करो तो audio is not there. Audio nothing? Okay. Anyways, we'll stop it then. We'll just discuss because audio is very important. But if you can see the reaction, okay, from the audience, how many of you felt that they have done brilliantly? They have done brilliantly. Could they have done something else, a better way, or you would have done the same way? Yes. एक माइक ऑडियंस में दे दो ना. Yeah. So fulminant DIC. So what all you want to send when the patient collapses? Remember CBC, ABG. More importantly, even if you don't get an arterial sample, don't bother. Send a venous sample. What I want is lactate. I want pH. I want bicarb, and oxygenation. Anyway, I know saturation. So I may not be bothered much, but at least I know the carbon dioxide levels. So if you have an arterial line, if you can do an arterial puncture, fine. If you don't have an arterial puncture, if you cannot do arterial puncture, don't have to bother about doing that. Just send a venous sample for ABG. Okay, very important. When you're sending the sample, see that there are no air bubbles, and because there are 3 machines, you said, you put in a cold chain and see that you get the report urgently. That is one. What else you want to send? Creatinine. Yes. What else you want to send? LFTs. Because we don't know, it could be undiagnosed preeclampsia have severe features which we don't know. What else you want to send? Coagulation profile. PT, APTT, fibrinogen. Fibrinogen. So, what else? Ubiquitously available in all ultrasound machine. Ultrasound machine is available in all labor rooms. Just put an ultrasound probe on the lung. And I don't know how many of you are well versed with doing an echo. I think next 6 months, each one of you should get practice.
Cure the airway.
ABC.
Yeah.
So A, Hudson's mask, nasal oxygen, no. Go for high flow oxygen mask, 12 to 15 liters of oxygen. If you have an anesthetist, give 100% oxygen by Bain circuit. Give a maximum FiO2. Then B, breathing. If she is breathing adequately, fine. If she is not breathing adequately, then you may have to put the tube. C, circulation. Put wide bore cannulas. How many of you routinely use pink cannulas in your practice?
Pink.
Sir, I have, sir, wherever I work, I ask them to put 18 gauge cannula in an obstetric patient, always.
So I know obstetricians are very fond of pink color, and pink color is again
18, green.
So go for green, NV.
So actually,
Grey.
now the Foxy recommends that we use the grey cannula
Yeah.
in all obstetric
Absolutely.
patients. So
I'm very
as
happy if it is this color also.
And sir,
so as a rule for any obstetric patients we do use the grey cannula.
So green is the minimum. So
yes.
A, airway, 15 liters of oxygen. B, breathing, intubate. First attempt is the best attempt. Use video laryngoscope. If you fail to attempt with, if you don't have video BLS, conventional laryngoscopy is failed, go for supraglottic airway device. Aspiration बाद में देखा जाएगा. At least airway is important. And when I say supraglottic airway, second generation LMA, just put a nasogastric tube, decompress the stomach. And at the same time give antacid prophylaxis. Okay? Circulation, C, circulation. 2 wide bore cannulas, start fluid, start vasopressors, which are appropriately started. You started non-adrenaline, and that's what saved the patient, and you started adrenaline also was given. But the cocktail of evil, deriphyllin, hydrocortisone, refrain from those things. Because deriphyllin, why deriphyllin?
Because the chest there is a crepitation plus.
And somebody was telling mannitol. What is the role of mannitol?
Brain protective.
No, somebody was, I could hear some mannitol also.
No,
So
sir,
mannitol should not be given. Mannitol, the only indication of mannitol is traumatic brain injury or any patient with raised ICP with peritumor edema or midline shift. Yes, otherwise there is no role of mannitol, traumatic, yeah. So, just furosemide, you want to give furosemide, yes, but when you are giving furosemide, support the circulation. Support the circulation. BP of 70, start noradrenaline first. I don't know when they were doing, could you have improved their communication? Could you feel that there was a window for improving communication? Madam?
There is a lack of communication. I couldn't hear the statement. So one should be the leader enough to see the screen and should give order. Here no one can, like here individual person is trying to save the patient. So there is a cocktail. So we are seeing the heart rate is going up to 190 and like up to 200. So because of the mixture of the adrenaline norad. So what I think is here really lack of communications and
Dr. Pramila, please give 40 milligrams of furosemide. Dr. Pramila should get back 40 milligrams of furosemide administered, ampule, cross-checked, kept in the discard tray. Because that is what is closed loop communication. You have instructed. So, in the event of crisis, address the person by their name. So that they know whom you are. Otherwise, give furosemide, 10 people will load furosemide, all people are there. So that should not happen. So instruction should be personalized and it should be closed loop communication. So you give adrenaline. Give adrenaline, kitna adrenaline, kitna vampire, IV dena, IM dena, subcut dena, kaisa dena. So give 1 milligram of adrenaline, dilute with 10 ml of saline, give intravenously, push 50 ml of saline after that. Pramila, please do this. So, and she has to get back with the closing the loop. So instruction is personalized to one person. You take care of grouping cross-matching, get the blood. You take care of injection. You look at the, you help me with intubation. You help me with resuscitation, get pressure infusion back. So all these instructions should be closed loop instructions, closed loop communication. So communication is very important.
I think that's not a very easy thing to manage. Because when you're adrenaline, when you yourself are in adrenaline rush, as when the patient is collapsing and everyone is trying to help the patient out, it's very difficult for an individual to stay calm at that point of time because of the sword that's hanging over your head. So I think it's easier said in theory at this point of time rather than in the OT scenario as to when that might happen.
No.
So even then, no matter how many simulations you do, no matter how many cardiac arrests you'll feel, this is not going to happen. It will not happen. It will, and to identify at that point of time, the person who's going to be in charge of the ship is very important. Because as you said rightly, for now, when I was there with him, and I saw there is no obstetric cause causing this collapse, it's better to take a seat back and let the anesthesiologist manage it. So that's the important thing, rather than trying to interfere. That's what I'm trying to say. But even though whatever you try and do, no matter how many maternal deaths you've encountered, you're still not going to be able to stay calm. It's all good in theory.
See, we know that, whenever there is a crisis, staying calm is very important. It comes with experience. It comes with grey hair. Probably, I have got grey hairs. You are still yet to get. So, what I mean to say is, you can stay calm. At least you may have those, you can like a swan or a duck, you can see what is happening underneath. But on the surface, it looks at least duck is calm. So that is what is the situation here. Because what happens is if you shout and yell and this thing during crisis, things will just go haywire. And control is very important. Importantly, suppose if you feel there is no obstetric cause, put the patient straight, you can go to the head and help your anesthetist.
Absolutely.
So, and vice versa. Vice versa. So it's basically, as I said, there is a symbiotic relationship. Very, very important. So, in this case, probably we were dealing with either sepsis or cardiomyopathy or heart disease complicating pregnancy or probably anaphylaxis or embolism, pulmonary embolism. We don't know. So, high BMI, pulmonary embolism could be there. So, the thing is, what we need to do is, okay, in this case, when the patient stabilized, how would you have discussed amongst your team member?
Once the patient is stabilized?
Like patient, at the end, the patient relatively stabilized, no? SAT come to about 88%, pulse rate had dropped to 140, and BP was around 88 by 70.
Initially, as soon as the patient is stabilized, I think we'd want to finish suturing of the episiotomy, get it over and done with, and probably shift her to a high dependency unit or a ICU setup.
What instructions you want to discuss with your team before you go?
So, correct. So, one sec. So, usually that happens once the patient is completely stabilized. Once the patient is completely stable, we go through with our team as to what is the events that have taken place, what we feel has been the cause of what has happened, and what we are going to discuss, or what as a lead obstetrician, because whatever happens, even if it's obstetric or non-obstetric, at the end my head is on the line. Because the patient has never seen the anesthesiologist, the patient has never seen the physician, patient has never seen anyone. So the only person who's going to head on line is going to be me.
Yeah.
So what we discuss is what are the events taking place, what are the events that's going to happen, what are the questions that we are going to answer. The other thing, if possible, is to instruct the staff not to discuss the case, to discuss all those questions to me.
So, thank you very much for bringing out that point. I wanted to convey that point. So, there is something known as WHO Surgical Safety Checklist. Are you routinely using in your practice?
Sorry?
WHO Safety Checklist.
Yes, every patient, every time.
Every patient, every time, that's a good thing. But there is something known as sign out.
Yes, every
so
patient, every time.
Signing out, what should be your sign out instructions in this case?
So,
to the team. So that everybody is on the same page.
So, what are the events taken place? What are the record keeping? Complete the records. Make sure that their entries are put on time exactly as to what traces have been given. Sit with the anesthesiologist, complete the notes right there and then, and only then shift the patient out, along with the instructions to everyone that this is the flow that has happened. Make it clear and make sure that's the only way or only message that comes across to the patient.
And sometimes there is an electronic record is also available, like the printer form from the monitor also. So we can keep that record for our safety.
Yeah. So basically debriefing, signing out is very important. When I'm signing out of the thing, okay, more likely we are dealing with A, anaphylaxis, B, sepsis, 3, cardiac causes. We need to get cultures, send cultures rather, or get an echo done, shift the patient to ICU, put her on mechanical ventilation, or I don't have facility in my hospital. What do I do? Because 80% of deliveries today in India happen in nursing home, where you have a solo practitioner, solo anesthetist, solo obstetrician, solo nurse, 10-bed hospital, 20-bed hospital, 30-bed, whatever may be the thing. So in that case, when this patient has gone through such high crisis, like say profound hypotension, and we don't have facility, echo kal hoega, technician aayega nahi, then better to stabilize and transfer the patient. But transferring the patient is very, very crucial. Do not transfer an unstable patient who is bleeding. So stabilize the patient and ensure that while you are transferring the patient, some clinician with experience accompanies the patient. इसमें problem होता है. Suppose if I accompany the patient, responsibility will be coming on my head if something happens to the patient. So before you do all these things, see that the communication is done properly. Like suppose if this patient is transferred to X hospital or 20 kilometers away, the X hospital has been informed.
Also, what we do here when we are transferring is, or in a crisis, is that at that point of time, once the patient is stabilized, we make sure, we ensure we introduce the anesthesiologists, the physicians, and the helping doctors to the patients and the relatives as to who are the concerned people who have helped to revive the patient, who are the concerned people, and to show that adequate help from a specialist has been obtained in maintaining or reviving the patient. Sometimes you'll succeed, sometimes you won't. But when you succeed, that's fine. But when you don't, it provides enough of an evidence or enough satisfaction for the patient that adequate care has been taken to ensure correct people were available for the job.
Exactly. In fact, very well said. So the thing is, like suppose if I can handle this patient, and if it looks like sepsis, how would you manage sepsis? How would you manage sepsis? Let's septic shock. Let us say septic shock.
First, hemodynamic stability.
Yeah.
It should be ensured. Then antibiotic coverage.
So what antibiotic coverage you want to give?
That is after some broad spectrum antibiotics.
That's exactly, some broad spectrum. That's what I want to come out. What is that some broad spectrum? Because in the event of septic shock, 1 hour of delay in administration of antibiotic will increase mortality by 10%. 2 hours, 20%. 3 hours, 30%. So administration of antibiotic is very crucial if it is septic shock. So what should be the antibiotic of your choice? So generally the dictum is hit hard, hit fast. Hit the bug hard. Start with 5% tazobactam with metronidazole or meropenem 1 gram or 2 grams loading dose over a period of 30 minutes and subsequently as an infusion for 4 hours. So, and send, but more importantly, 5 things, as I said, Panchamantra of sepsis, Panchamantra of septic shock management. Measure lactates. When I said blood gas has been sent, they asked for pH. I said pH 7.1. But I would have been happy if you had asked what is the lactate level. I would have been happy if you had asked what is the PaCO2. Because PaCO2 is 100. That means pH is purely respiratory acidosis. Because patient was hyperventilated also. So you need to be very specific what you want and what you interpret. Because many times we ask for blanket investigations. So interpreting investigations also is very, very important. So lactate, measure lactate, send cultures, give wide spectrum antibiotics, start fluids. So what fluid do you want to give?
Ringer lactate.
Ringer lactate. How many of you have seen HELP syndrome and AFLP in your practice? HELP syndromes and acute fatty liver of pregnancy?
Very rare.
Very rare. You have seen. So if it is acute hepatic failure with acute fatty liver of pregnancy, would you still give ringer lactate?
No. Then no.
Then what do you want to give?
Normal saline.
Normal saline. If the patient is having oliguric, what do you want to give? pH 7.1. Normal saline also will cause hyperchloremic metabolic acidosis. So, because see, in the event of hepatic failure, liver dysfunction, HELP syndrome, generally they don't have liver failure. But acute fatty liver pregnancy, acute viral hepatitis, hepatitis A or hepatitis E or dengue, or any of those things can cause fulminant hepatic leptospiral infections. I don't know how many of you have seen leptospirus or scrub typhus complicating pregnancy, but we do come across some of the, because it's our referral center. So when you have underlying liver dysfunction or liver failure, ringer lactate is relatively not safe because lactate is ideally converted to bicarb in liver, and this conversion does not happen, and lactate gets accumulated and can cause lactic acidosis. So the ideal fluid will be in this scenario a balanced salt solution, or like capillite or any of this. Again, nil conflict of interest for taking those names, but yes, balanced salt solution should be available in most of the hospitals. But if you have nothing like it, still give ringer normal saline. Something is better than nothing.
Isolate type solution?
Isolate M.
Sir, for ringer lactate and normal saline, ringer lactate is better in any scenario.
Absolutely. Ringer lactate is always
because
better.
in normal saline, only name normal is the only thing. Otherwise it is not a normal.
Yeah. So if you see ringer lactate is little hypoosmolar, normal saline is isoosmolar. Balanced salt solution are mostly isoosmolar. So that is the fluid of choice. So how much fluid you want to give? Pressures are 70s and 80s. How much fluid you want to give?
See, according to the urine output.
Output is hardly 30 ml.
Then first you give fluid challenge test. 1 liter of fluid you give fast. Then you see the urine output. You auscultate the chest. If it is normal, then again 500 ml more you can give.
So what is generally discussed and we practice is fluid is double-edged sword. Yes, 20 to 30 ml per kg, roughly about 1.5 liters of fluid is okay. 2 liters up you can give. But beyond 2 liters, if the patient is not bleeding and you give you have more problems. Because in septic shock, in dengue, in any of those things, there is a capillary leak. So whatever you give leaks out into the third space and patient becomes bloated, almost swollen edema, swollen this thing. So it may not be safe. So you need to go for targeted fluid therapy.
Also, I think at that point of time, you've probably got an echo done to make sure that the cardiac is okay before you do anything else.
So echo is very important, very important. So you can what targeted fluid therapy, you can go to IVC ultrasound, there are many objective ways of measuring fluid optimization. So measure lactate, send cultures, give antibiotics, hit hard, hit fast. 1 hour delay in administration of antibiotic in septic shock is going to cause morbidity or mortality by 10%, going to increase morbidity and mortality. So septic shock is a life-threatening emergency. You have to remember that.
Sir,
Fluid-
colloids and crystalloids, which one is better?
Absolutely no colloids. Colloid is banned. Colloid usage should be condemned, especially with septic shock, because it is going to induce acute kidney injury. No colloid, no starch, no gelofusine, no hemaxil. Only colloid if you want to use is 20% albumin. If it's a hemorrhagic shock, give blood. That's only colloid. Sir.
Non-hemorrhagic shock, including septic shock, I think the best thing that you can do is put in the central line.
Absolutely.
For a CVP. And not just depend on the blood pressure monitoring or
urine output. You have to put in a central line because that is going to be of great importance. All non-hemorrhagic shock in obstetrics.
Sir, nowadays CVP is obsolete. They do echocardiography and assess the.
See, the thing is,
sir, it is also double-edged sword. CVP is also.
I'll come to it. So basically, again, there is a lot of thing about central line, peripheral line. Central line, definitely, if you have the know-how, if you are comfortable with putting central line, go ahead and put it. But in the event of crisis, insertion of central line is going to take minimum 15 to 20 minutes. And those 15-20 minutes are very crucial. So even if it's a septic shock, initially I would refrain from putting central line because I don't want to waste those 10 minutes or 15 minutes. Instead, if the wide bore peripheral cannulas are there, you can give temporary vasopressors, inotropes through the peripheral line. Once the patient stabilizes, definitely you put central line. And central line definitely for directing vasopressors, inotropes, not for measuring CVP. Okay, because it's fallacious. So central line definitely is helpful, but during crisis, it may, unless you have experienced hand and you can pick in, you can put it, don't waste your time in central line. Once the patient stabilizes in the ICU, definitely you can put a central line. So wide bore cannulas, fluid resuscitation, so measure lactate, cultures, antibiotic, fluid, inotropes and vasopressors. You said noradrenaline. Noradrenaline to start kiya, blood pressure is still not coming up. What do you do? Septic shock.
Then I will give soda bicap and then again adjust the dose of noradrenaline.
See, when you have septic shock, the recommendations are, if the blood pressure is not improving with fluids, simultaneously start noradrenaline because it will constrict the pipes, it will help in upgrading the blood pressure. If the pipes are still flaccid, like vasodilated, then go for vasopressin. Vasopressin is a good potent vasoconstrictor. So noradrenaline, start vasopressin. Take 20 units of vasopressin. Each of the obstetrician must be having vasopressin because they use for myomas infiltration. Use vasopressin. Start 4 ml per hour. That will tremendously increase. If it still doesn't help, you can go for adrenaline. So norad, vasopressin, adrenaline. And if this patient has sepsis-induced myocardial dysfunction, low-dose dobutamine also should be. What I mean to say is, target MAP of at least 65 to 70 millimeters of mercury. Not less than 50, but at least 60, 65, because we want to maintain adequacy of urine output. So, again, lactate, cultures, antibiotic, fluid, inotropes, vasopressors. And more importantly, simultaneously look for the source of sepsis. Is it pneumonia? Is it appendix? Is it cholecystitis? Is it pyelonephritis? Is it breast abscess? Is it chorioamnionitis? Is it urosepsis? So you need to identify the source of sepsis. Because if it is chorioamnionitis, delivery helps. So if you are suspecting chorioamnionitis as the cause of septic shock, like patient has PRM of 12 hours or 13 hours or 20 hours duration, then send high vaginal swab culture also. Importantly, discuss with neonatologist. I am suspecting, like in this case, probably neonatologist also should have been in the picture. Sir, septic shock to nahi hai na? Baby also is little low on Apgar, hypotonic. So, do you think I should send blood cultures in the neonate? Because there have been instances where the same bugs have been born from the mother as well as the baby, the fetus. So, you can proactively prevent neonatal sepsis and neonatal death also. Very, very important. And the best source of culturing organism in chorioamnionitis is the placental bed. So, send a cotyledon or the placenta which you removed for culture. So, blood culture, culture from the cotyledon and neonatal blood culture, all these things should be done in a case of septic shock. And after 48 hours, once you obtain the culture, you can always come down and de-escalate antibiotic. So, yeah.
The other thing is, usually if there is septic shock or if there is some sort of sepsis, even when you first examine the patient, you'll just notice there's fever. So that's what will start your brain rolling to begin with. Once a patient usually presents to you with no fever at all, it's unlikely that there is some sort of sepsis that's happening.
See, this is exactly what I want to bring about. There have been many cases, I have seen plenty of cases who are absolutely asymptomatic, but they have been admitted with UTI 1 month before delivery in some other nursing home. And the bug is still in the uro system. And our patient has had a rescue cerclage done 2 weeks back elsewhere for cervical incompetence, pelvic rescue cerclage. And you had a nick in the amniotic membrane, now he has ascending infection. So, patient will be absolutely asymptomatic.
If there is chorioamnionitis,
false smelling discharge, raised TLCs, all will be seen. But sometimes they will be asymptomatic also.
The thing is, what I'm trying to say is, when you are presented acutely, you don't have the time. By the time your culture reports have come, you already have an outcome with the patient. The question to you is, that's fine. It's great to do a sepsis. It's great to do a culture. It's great to do a blood culture. It's great to do, but are you going to wait for the result?
No. That's what I'm trying to tell you.
Correct. So the point is that at that point of time, how important is it to do that?
See, again, I'll refresh. Probably I was not clear in what my approach was. Whenever the mother collapses, go by the algorithm. Suppose the counts are high. Let us say in this case, WBC count is 20,000. 20,000 WBC count you see also in anaphylactic shock of pregnancy, acute leukocytosis. Post-delivery, you can see, sickle crisis. You can see WBC count. So, is this WBC count because of sepsis, because of embolism, because of anything else? You need to have an algorithm. So, an appropriate pathway has to be followed. Or sometimes you can have mixed of two disease entities.
My only reasoning is that it's fine. It's actually, it'll absolutely, what you're trying to say is will absolutely help us medically. That's one. Second thing is, as a clinician, 5 days have gone by once your reports, or whenever you've got your reports with the culture and sensitivity, you already know what the outcome has happened. So, as a clinician, the dependency on those reports is going to be minimal at best.
See, initial management is all symptomatic management. But at the same time, you need to give targeted management also.
Correct. But that time, like you said, pneumonia, you'd already have done CT, etc. Everything that's available, you would have already done by the time.
What I mean to say, see, basically, in a nutshell, the point which I wanted to highlight is, because we don't have sepsis scenario today, I am discussing more elaborately about sepsis.
Correct.
That is one thing which I wanted to bring forth. It could be anaphylaxis, it's easy, most of us know. Hemorrhage, we'll be discussing, hence one more scenario is there. But importantly, the point which I want to emphasize is sepsis kill the patient. Hypertension, hemorrhage and sepsis. If you can control these three preventing preventable cause of maternal death, preventing preventable causes of maternal death, you can bring down your MMR to less than 30 per 1 lakh deliveries. So that is what I wanted to convey. So I was discussing a little more about septic shock because we are not very familiar with septic shock management.
We don't see it also very often.
Most of the times in sepsis, what we see, the stage of fever, the stage of tachycardia, and the stage of even tachypnea may not be coming to us in the picture. What we see is a cold patient with some tachycardia, even some respiratory rate is increased, and these are the patients usually we come across. The third stage is mental confusion. So if you see a patient who is confused little bit, be aware that you are entering almost into a very severe sepsis before you get the clinical reports. What about steroids?
I'm coming to that. So if the blood pressure is still not coming out, the isopressors, inotropes and noradrenaline, then yes, you can give hydrocortisone 50 milligrams 6th hourly. For hydrocortisone 50 milligrams 6th hourly. Solimedrol you can give, there is nothing wrong, but at least hydrocortisone is short half-life. You can give up to 48 to 72 hours. Once the BP stabilizes, you don't have to taper it off, you can stop abruptly. So septic shock, Panchatantra, lactates, cultures, antibiotics, fluids, inotropes, vasopressors, noradrenaline, vasopressin, adrenaline, dobutamine, whatever, but maintain the map. And 6th is terminate the pregnancy. Cardiogenic shock, why not peripartum cardiomyopathy? Possibly. So how do you tackle peripartum cardiomyopathy?
I think first to diagnose it's very important.
So diagnosis of exclusion.
Plus also if you are at the right place at the right time and you've managed to get a 2D echo machine to just identify what is going on, you'd be lucky. But it's rarely the case that happens.
So when the patient is not bleeding, when there is chest is clear, when there is no wheal, flare, redness, it looks like anaphylaxis, and the WBC count is fine, am I dealing with cardiac cause? I have given already oxytocin. Oxytocin must have worsened or precipitated. So think about those things also. So
also as obstetricians, a lot of us use isoxaprine, duodelan, as we said. That particular drug in patients who have been administered has now been known to increase the chances of cardiomyopathy, whether it is antepartum or peripartum.
How many of you use duodelan in your practice?
All of us, I guess.
Take an oath today.
Very narrow margin of use of duodelan. If patient is not in labor, prophylactically, no.
No.
Not at all. This prophylactic use of isoxaprine is absolutely out of practice. Another thing, if patient is already in labor, duodelan is not going to work. The action of duodelan, which is suggested, is if patient is in early labor and if you want to buy 24 hours for the steroids to work, there you might be justified. But you have to be very careful about tachycardia and pulmonary edema.
So all beta-2 sympathomimetics like isoxaprine, terbutaline, or this ritodrine, they are notorious for hyperglycemia, hypokalemia, fluid retention, and acute pulmonary edema and stress cardiomyopathy, as sir said rightly. So cardiomyopathy is very common with beta-2 sympathomimetics. In fact, last 15 years at Fernandez Hospital, we have not used duodelan. We stopped using it. And they manage this threatened preterm labor with using magnesium or nifedipine, any of those things. But what happens is, these patients with duodelan, with preterm labor, you give steroid for fetal lung maturity. So combination of fetal, if you see steroid also cause hyperglycemia. Duodenone will cause hyperglycemia. Steroid will cause hypokalemia. Duodenone will cause hypokalemia. Steroid will cause fluid retention. This also will cause fluid retention. And it's a deadly cocktail. Importantly, asymptomatic sepsis, occult sepsis will become overt. Occult heart disease will become overt. Or cardiomyopathy can be induced. Like if you see the Takotsubo cardiomyopathy, the broken heart syndrome, is common with all these entities. So do not use, or you should use these things judiciously. They are double-edged weapon. So suppose in this entire scenario of hypotension, tachypnea, hypoxemia, how, if you are thinking as a cardiac cause, how would you manage? Same thing. Probably I will be more restrained about fluid. I will not go for 30 ml per kg. I will be more emphatic on inotropes, vasopressors, echo, intubation, airway management, and importantly, oxytocics. Oxytocics should be used very, very judiciously. Okay? So, PAC R square. Preload, maintain preload. The best way to maintain preload in pregnant patient is manual left uterine displacement with head up tilt. Okay? MLUD. By putting wedge under the right hip or causing or pulling the uterus to one side will improve the preload by 25 to 27%. A, afterload. How do you improve afterload? By increasing contractility, also by reducing SVR, or by increasing SVR. If the pressures are low, go for vasoconstrictors. If the pressures are high, go for vasodilators. Simple. Okay? So vasodilators, very, very fond of, very frequently used, we are NTG, labetalol. And vasoconstrictors, noradrenaline, adrenaline, dobutamine. Only remember, levosimendan, and all those things are there, but you don't have to use them in your dictionary. Just have 3 of them or 4 of them, vasopressin, if septic shock, and be comfortable with what we are using. So, vasopressors, PA, C is contractility. Enhance contractility by whatever means. So, I need to stop all those medications which reduce contractility. Suppose if I am putting this patient under general anesthesia, I would like to reduce or optimize inhalation agent. I would like to reduce benzodiazepines. If I am like midazolam and other things which can cause myocardial depression action. So contractility can be improved by using dobutamine or adrenaline, direct sympathomimetic beta-2 agonist, beta-1 agonist. Then R square, rate. Control the rate. If the rate is very low, you can give atropine or glycopyrrole. If the rate is very high, go for rate lowering drugs. But again, rate lowering drugs are negative inotropic, chronotropic. So you just give volume, give vasopressors. If at all the rate is very high, then you can give, if it is a cardiac origin arrhythmias, then you can give adenosine or any like a smell or short acting and bring down the rate. Xylocard if there is arrhythmias. Yes, sir.